Whereas the serous tissue is mainly on the pleura, on the pericardium, peritoneum, and there are many other areas. Arthritis joints are serous tissue as well, and there are small parts in the body as well. What the importance of serous tissue here? These are just the example of the organs you might get serous tissue or serositis in it. The importance when you have your autoimmune disease, you know what you are dealing with. But the few scenarios we face that the first presentation is serositis. And sometimes things can get very wrong in how you manage that serositis and how you made the diagnosis. Hence, we brought this topic, and in the way we are going to show the challenges and scenarios that you hopefully you find it useful in your clinical practice. These are the rheumatic conditions mentioned to have serositis in it. The main three I'm going to focus about are these three in red, which I'm going to mention in more details. However, you can have serositis in other conditions as well. So serositis as a presentation, it can be in the pleura, the most common one, or pericardium, as we said, could come as effusion, could come as pain when there is little fluid, just a pain. Functional compromise like pericarditis could come with a failure, or secondary infection. When there's a fluid stagnation, you get infected. And the first challenge usually, which usually chest physician or cardiologist face that, is it exudate or transudate? And they do the whole battery of fluid analysis. And from fluid analysis, we try to differentiate they are exudate or transudate. Also cytology, culture to look for infection is a quite common cause. And there is another test not variably available called adenosine deaminase. A simple diagram for this one, exudate is when there is an active process, either inflammation or cancer or infection. When transudate, when there isn't active process like those, but there is some hemodynamic compromise in terms of liver failure, kidney failure, hypoalbuminemia. So there is a fluid, osmotic pressure, and so on. The simple analysis or definition of experts is what is represent exudate in terms of a protein to serum protein ratio, LDH, glucose, all these you see cells, and transudate is usually when you have less of that. However, this is not like very much a clear or definite guidelines. I remember when I was studying in my medical science, I mean, chronic heart failure could give you exudate sometime, although it's mainly should be a transudate producing condition. So this is not always true. That's why this is one of the challenges you could face in the beginning and one of the scenarios we've seen as well. And when you have an exudate, as we said, there is either active pathological process, infection or malignancy, but also there is an autoimmune, which is the part we need to clarify on this occasion, and also the pulmonary embolism, which sometimes are linked to the autoimmune disease and sometimes not, and other kidney disease as well. The main difference in when we have a pleural effusion, the main difference could be with the aspirate fluid. So aspiration of fluid is very important. Cleaning symptoms, you get it analyzed, but doing that too often or too repeatedly is going to have the risk of infection itself. So we have to be careful. We might aspirate at once. We try to find the diagnosis before we decide how are we going to treat that condition. And you see some differences between what you call lupus, what you call rheumatoid. Lupus serositis, as I said, one of the conditions we talk about mainly lupus, because most of the presented unidentified serositis for the first time might well be lupus. It could be other things, but lupus is higher in probability. Could be pleuritis, could be effusion. There are classification criteria for lupus just recently been, last year being published. And the pain, shortness of breath, exudate on aspirate with the high LDH as we described. However, when you suspect lupus or you thinking about lupus, you have to think all the possible co-pathologies comes with lupus, including pneumonitis, including PE, including interstitial lung disease. These might be contributors symptomatically. So these are the classification criteria. They are not diagnostic criteria by any means. That's always been said. This is for research. However, we quite often see diagnostic line is more or less close to classification line to make ourselves reassured as well as patients reassured. And on these guidelines, it's been stated that we need more than 10 points to be classified as lupus. And if you look at the pleural or pericardial effusion, you get between 5 or 6 points. So you are not far from reaching a diagnosis if you find one other key element or two.
So Asir, can you close please the color box?
Can you?
Color box please is covering the slides. In your screen, there's color box covering the slide.
Color box, I don't know what you mean.
There is, I think you did right click of the screen, so there is something appearing into here for us.
All right. Still, I cannot see what you mean.
Okay, click on the screen with the mouse, please. In the mouse, in the screen.
I don't have mouse. This is laptop.
Can you move your cursor to the screen?
Yeah.
Okay.
I'm moving it as well.
Okay.
I cannot see what you.
I cannot see your arrow. You can let us see your arrow with your screen arrow. Just.
No, I cannot see my arrow now for some reason.
Cannot see it. Yes, I think there is. Okay, can you exit presentation and
exit?
Start?
Yeah. Okay. I think I'll do that. Yeah. Okay, we are here. We are here. Okay. What about? How is it now?
Still appearing.
Sorry?
Still seeing a color box.
It's still seeing.
Yes.
Where is it about on the screen?
It will be on your maximum of the right side. The end of the right side.
I cannot figure out what is in there. Because I have your photos on the right hand side. What appear there. Let's go to, yeah, sorry about that. Let's go change the screen. What you call it? Yes. This one, what you mean?
Yes, now
I see. Yeah, okay. I don't know how it appears. Is it better now?
Yes, perfect. Go on.
Perfect, yeah. Sorry, that was I was changing in the presentation. I don't know why it's up here. Anyway, so we come back to lupus pleuritis, which is the most common serositis of lupus. Usually non-critical, usually mild, slowly evolving, and usually favorably respond to steroids. And recurrence is one of its main features. It needs immunosuppression to minimize the recurrence pattern. And another study showing that the percentage of serositis. And interestingly, on this study, the percentage of peritonitis, nearly a quarter of lupus might have peritonitis. I can clearly confess that I don't have that percentage. Maybe most of us might not have this percentage because we don't look for it. What's obvious there and clearly symptomatic is the pleuritis and pericarditis. But there are many studies mentioning when they do it to study it academically by CT scans and other things, they might find the fluid at a higher percentage. So we should keep this in mind as well. And effusion, when it comes to effusion, it could be part of the, let me say, pleuritis. But when it is large enough, you always have to think of the comorbidity. Comorbidity is well common in lupus patients. So that's also keep it in mind. And usually they are active, serologically active lupus. Predictor factor, mainly low C3, elevated dsDNA and high ESR. And always be aware of D-dimers. I'll talk about D-dimers later on, because people are misusing the D-dimers in many occasions and people goes into the wrong track of investigation and treatment. So This is a sign, an X-ray of pneumonitis. When it comes to the pleuritis, people might think of the pleural effusion or pleuritis, and they just not focusing enough on pneumonitis. Because if you take that in consideration, all your management going to be more aggressive treatment-wise compared to the pleuritis only. So you have to keep this in mind. What triggered me to put this lecture together is this case. A 73-year-old lady, she had 2 years history of recurrent pleural effusion and aspirate. 2 years for such a case, which we prove later, is just too long. They should ask me after 2 months, perhaps, when they investigate enough and they find nothing, not 2 years. She always had high ESR-CRP, and she had mildly elevated tumor markers, CA125 and CA19. So that's what made them, let me say, investigated thoroughly for cancer. And she had CT scan, no malignancy. She had CT abdomen, no malignancy. She had PET scan, no uptakes. Pleural biopsy was inconclusive. And only then Dr. Shukur, my colleague in Mediclinic, say, would you mind come and see this lady with me? This lady has pleural effusion, aspirated down and then accumulated again and aspirated again, and just repeated cycle of aspiration and accumulation. When I just look at it, she never had autoimmune disease investigations. We've done ANA and we found low C3, low C4 as well, and she has a neutropenia. And when you look at these classification criteria again, when we need 10 points, we have nearly 8 or 9 points on this side. With the neutropenia, 3 points, we get 11 points. So that's what make it as a diagnosis. And we could prove that on management platform. So I told her, look, you look like you have a lupus, and we have given her steroids. All parameters you can imagine, ESR, CRP, everything improved. Shortness of breath gone, no more accumulation of fluid. But whenever we tried to taper steroid before 15 milligram, she accumulated fluid again. Therefore, we added azathioprine and hydroxychloroquine initially. Then we stopped the second one, and she is stable on azathioprine and only 5 milligram prednisolone. She feels a bit symptomatic, less than that. Right, one of the lessons of this one, which I found these two studies, that CA125 has been associated with active rheumatoid arthritis without the presence of cancer. And that's one of the misleading and lesson of the case, that tumor markers are not diagnostic markers. These are used only when there is a cancer for follow-up. While they have share, they are not inflammatory themselves as such, could be, but also share similarity to rheumatoid factor FC portion in terms of assay. That's why they become positive. And this is another study showing this correlation. And most of the patients studied on this one, they found no cancer on the follow-up, and it's mainly related to RA. So if it is high in RA, it could be high in other autoimmune and rheumatic disorders as well to some extent. So that was a lesson from that case. The other case is just recently, I only remember her yesterday night, added the details, but I don't have the x-rays for her. She's 45-year-old Egyptian, came with shortness of breath. She had lung infiltrates. They thought metastasis. She had high ESR-CRP. She had high fibrinogen and D-dimer. It's true, fibrinogen D-dimer are not very specific, but can give you some hint of what is the problem. CA125 again increased to more than 200. Scans, chest, abdomen again, no finding of cancer. The patient is very worried. She had a weak lupus markers, ANA and lupus anticoagulant, and we gave her steroids. The lung infiltrate disappeared, and the CA125 dropped to 120. So we are not treating cancer, we are treating inflammatory process, but the CA125 dropped down. However, from experience, we will keep vigilant on any possible malignancy through regular observation and follow-up. We come to the other part of lupus serositis, which is peritonitis. Its claim is around 10% of SLE patient. This is high for me. I don't do routine ultrasound or CT. However, when you get fluid in the abdomen and you just don't take it, it's serositis straight away. It's quite possible. But with the lupus multisystemic disease, you need to think of nephritis and you need to assess the kidney function in that respect. The author of this study found most of mild cases could be inactive lupus. However, he say peritonitis might require high dose, which I think we only pick up peritonitis when there is acute abdomen and there is CT finding of a good amount of serositis over there with the fluid. And therefore they require high dose, similarly to pericarditis might require high dose steroid. So abdominal peritonitis is often perhaps picked up when it is severe. And that's why it's overlooked and could be mild in many stages of the disease. Now we come to another entity, which represents serositis. And I think this entity has also a lot of clinical problems in terms of management between multiple specialties. Those group of people, they gave classical positional pain of pericarditis, usually attend emergency department or cardiology. They have ECG echo, classical finding of pericarditis. In the past, they might use it, if it is once, they call it post-viral. But when it is recurrent, that's where is the problem. You cannot keep post-viral and it's happening again and again and again. They usually self-limiting for each attack. And the worry of the pain, they hear all the treatment. When I see them, I tell them this could be an autoimmune of some sort. They reject this concept. They say, look, my problem is with the heart, simply because of cardiologist opinion. They often have high ESR and CRP, And if we look at the immunological causes of pericarditis, there are between 5 to 15 of all pericarditis. And these are the conditions that might cause pericarditis. I want to highlight one thing here is inflammatory bowel disease. Inflammatory bowel disease quite often is a subtle inflammatory process. People come with non-specific inflammatory process, and only after a while we find out it is coming from the bowel. So always also keep this condition in mind. And what they call it, idiopathic recurrent acute pericarditis, the pathological study on it, they found excessive interleukin-1, interleukin-6, 8, and TNF in the pericardial fluid. Also, genetic studies showed there is some rare but shared mutation with FMF and TRAPS fever. So IRAP has been considered as IL-1 driven disease. It's important to raise this concept, IL-1 driven disease, what it means. The trigger pathway is IL-1, it's not IL-6, not TNF, or not IL-4/5. The features of this IL-1 driven disease is the recurrence. Even gout, crystals are there in the joint all the time. But why the attacks coming on and off? It is triggered by environmental factor. Similarly, FMF, they are also triggered with environmental factor. Still disease can have bouts up and down, and so on. So the IL-1 driven disease are mainly episodic feature, and the pericarditis of this type is behaving same way. It is recurrent. And recurrent pericarditis, usually treated with anti-inflammatory, could respond in 7 to 14 days. And it can drop the CRP as well, or maybe it's a self-limiting of the attack itself. It's important we keep treating pericarditis because the patient only thinking about pain, but we have to think of pericardial constriction on recurrent attacks. That's why the importance of treating this condition effectively. We can find it in other autoimmune disease. TB, again, is one of the features of recurrence. However, I would imagine TB can give you a persistent disease, a progressive disease most of the time. So when you say differential, as we said, I put autoimmune and autoinflammatory in a different points because autoimmune could represent the antibody-triggered disease like lupus or connective tissue disease, while autoinflammatory is triggered by interleukin-1 driven disease. And this is a diagram which I found is very helpful about how the process of triggering from inflammasomes to interleukin-1 and trigger a cascade of inflammatory changes leading to acute inflammation. And on this diagram also to show that aspirin and NSAIDs one could block this pathway to some extent, steroid as well, colchicine in the middle of the page. and also interleukin-1 blockers, anakinra, rilonacept, and more recently canakinumab. They are interleukin-1 blockers, and they find they are helpful in this group of conditions. So we come to a lady who traveled with this one. She is again Egyptian lady, central chest pain, pericarditis, had high ESR-CRP, and fibrinogen, which we'll discuss this later. NSAIDs, no improvement. She had colchicine, improvement, but around 50%, had recurrence. We gave her steroid, helps a lot. She doesn't want to stay on steroids. And then we are considering methotrexate in her case. And we'll explain why we need to give her the methotrexate. So whenever she goes on a low dose colchicine, she would have a problem. That are her figures. You see the scan showing the pericarditis. You see the chest X-ray. I'm not expert with echo, but echo is, for experts, could show the pericarditis there. The American guidelines in this pericarditis are either incessant, which means it lasts a few weeks, but then go into remission, or, without remission. Recurrence, again, similar period, but could be symptom-free interval in between, and the chronic is when they persist. Aspirin and NSAID is the first part of their guidelines, and then colchicine for 6 months is recommended. What about the refractory case? In our case, she struggled with the steroids, and then we needed, always needed every time. So it's more like becoming chronic or persistent. So what do? Isn't the guideline saying to offer methotrexate? And why methotrexate in particular? Are we treating lupus-like pattern? No. Methotrexate has interleukin-1 antagonist activity. That's why it came first in the guidelines, but at a later stage. Azathioprine, it's been mentioned in the literature. I'm not very fancy of it. IVIG and anakinra are all like being used in literature. I just want to mention something about colchicine. Colchicine, in my opinion, is the cheapest biologic ever we know, plus it's natural in some way. And why? It doesn't block IL-1 as we showed in the cascade, but it influences a lot of a process from the inflammasomes to inflammation, trigger that lead to the symptoms. Plus, also, it blocks TNF and in some way on TNF, because one of the problems of FMF-like disease is amyloidosis, and amyloidosis could be the cause of trouble later on. So colchicine is the best drug in FMF that would prevent amyloidosis. TNF could do a similar job in some way. So lessons from this case is that we need to go as the highest dose of colchicine, who tolerated and effective. Most people, they don't like tablets. They drop the dose by themselves and then they get recurrent attacks. Methotrexate, as we said, has some IL-1 antagonist features, and other immunosuppression therapy are tried on literature, not on the very clear pathophysiological basis. So when we mentioned FMF, because it's one of the IL-1 driven disease. This is a challenging story in the Middle East region. I didn't see many of FMF in UK, but I'm seeing here a lot. These are paroxysmal or periodical serositis, usually peritonitis. That's the opposite to pericarditis or pleuritis. Usually come with abdominal pain. They might have pleuritis, 40% and less of pericarditis. They can have arthritis as well. The acute attack, in many people, you might take many people's history, they had laparotomy or appendectomy. Despite the fact, that's one of the, for me, inviting surgeons to this occasion, that they always need to see anyone with recurrent abdominal pain to check for FMF story. It can affect scrotal attack, and as you said, acute joint attacks as well. The articular attacks are mainly large joints, mainly ankles or knees, occasionally metatarsophalangeal joints, not that often, and usually resolve rather quickly, but there is a chronic form of the articular disease. In the acute form, the onset is abrupt, associated with fever because at the end is a feverish condition. And believe me, we had many problems in these days when they have acute attack with fever and they end up having all corona tests and admission and suspicion corona, whatever it is. But I feel sorry for them. Usually single joint, occasionally oligoarthritis, usually lasts only a couple of days, sometimes triggered by trauma or a twist, which is environmental trigger factor. And this is like one of the attacks could happen, like ankle joint acute monoarthritis of FMF nature. The protracted phase can persist, stay for a few weeks, monoarthritis or oligoarthritis sometimes. It is important to know that steroids are not very effective in FMF arthritis pattern. Colchicine remain the mainstay for the management. And these can be associated with another condition, which we call it erysipelas-like erythema. And if you see that erythema, it will be like almost diagnostic. You don't need to think twice. Arthritis and this erythema, you say this FMF, particularly if you have the supporting previous history. And these are the type of erythema. If this erythema would remind you, for people who are experienced here, about what you call gouty cellulitis. We know gout, if it affects the first MTP joint, is joint swelling, inflammation, ultrasound features. But there is sometimes we call it gouty cellulitis. It's very much mimicking this pattern, usually on the dorsum of the foot. And there is also mimic, these are both IL-1 driven conditions in this situation. So other management of FMF, I said, NSAIDs would help in acute attacks. Steroids, often disappointing. Colchicine is the mainstay, as we said earlier. It has been FDA approved recently. Canakinumab could be used, which is IL-1 inhibitor, could be used in refractory cases. However, it is very expensive, sadly so. The epidemiology. This is part of the diagnostic clues. I mean, I keep telling my colleagues in the hospital, patients from the Levant area, Jordan, Palestine, Syria, and some Egypt as well, coming with a manifestation of the mentions, you have to think of FMF as first diagnosis before you go to broaden your differentials. And it's mainly genetic mutation. It's cause or lead to hyperactive inflammasomes that increase the secretion of interleukins and also TNF. So what are the genes? Some of you might be experienced with the genes, and there are many amino acids, and the main sites of genetic defect is in 694726. And this one is more severe. The first one is more severe than the other. However, there are 23 different mutations. There are different forms of FMF-like disease, like in Bulgaria or Tunisia or even Ukraine. They might have a slightly different pattern or manifestation, or some of them have more of a pleuritis or pericarditis. And that's why IRAP, which is idiopathic recurrent, it could be a different mutation from FMF. So it will be under the same umbrella one way or another. And the diagnosis and treatment for FMF, as I said, the diagnosis we have discussed it, usually comes with very high CRP. That's another feature, just like gout. During the attack, very high CRP. After the attack, the CRP gone down to earth. It is different from a chronic condition like synovitis. Often there is a mistake with them. And when they have more of a moderately raised CRP and ESR on a longer term. So NSAIDs would help. Colchicine is the mainstay, is the most important. Colchicine is the best drug to ameliorate amyloidosis. anti-TNF could do, but it is not a standard to give in FMF or gout, but there are studies on gout to say that. Colchicine, mainly there is an item called etanercept, Enbrel is what is studied for. Colchicine by itself can cause abdominal pain. That's why some people cannot tolerate very high dose. We have to escalate, go up and escalate up slowly, try to get to the best balance tolerated by the patient. Right, I mentioned fibrinogen in my studies, and now I do this test almost routinely, but many people, they don't do it. Fibrinogen is an acute phase reactant. But it's part of the clotting panel. Whenever you go to the lab, fibrinogen part of the clotting panel, because if it is low, cause hemorrhage, if it is high, cause clotting. However, it is one of the most, it is a key test between the inflammatory and the clotting interface. And it is, I'll show you this diagram. It is very key protein in the body, play a big part in both conditions. However, as I said, it's been only studied because fibrinogen, when it's degraded, we used to call it fibrinogen degradation products, or now there is a version of it, we call it D-dimer. These are taking attention, means there is a process of clotting happening. However, that is only half the story. Most clinicians, they think D-dimer is about clotting. That's not totally true. You have to keep in mind D-dimer and fibrinogen can be part of the inflammatory process. However, they represent the risk for clotting, and people we know in the studies, inflammatory condition, all have increasing chance of atherosclerotic and clotting disease, like lupus or rheumatoid. In many ways, it's because of high fibrinogen level. So increase of risk of thrombosis, but it's a feature of a chronic inflammation. It can lead to a high platelet figure, and also can trigger IL-6 in some way. TNF leads more to increased von Willebrand. These are all the causes why they contribute to atherosclerotic and clotting disease in inflammatory condition. I took this from the veterans that when they study the animal condition, they take fibrinogen. Fibrinogen gives them like a chronicle or like cumulative reading, similar to hemoglobin A1C in diabetes. Give you the condition over 3 months. And fibrinogen is like that. This is compared to amyloid, they also tested, but also compared to CRP. The CRP, like amyloid, goes up and down very quickly, but the fibrinogen would have some, let me say, cumulative factor to show the status of the person in the last few weeks. And that's why I think it has an importance in my practice, and I'll show you that. So once I've been called by chest physician, there was a girl with the unexplained chest pain, mild pericarditis, that's the clinical diagnosis. Cannot find serious pathology, just she had some pericardial-like symptoms, and sorry, I have to go back. Yeah. They found her D-dimer 4,000. I can tell you, she had all the tests for chest and heart, cardiac catheterization, echo, whatever, MRI, cardiac scan, everything, because of the D-dimer 4,000. So we need to learn the lessons from such cases. They were thinking of, is it vasculitis, lupus with PE, ischemic thing? When I check how, which I do a battery of inflammatory tests, that's my pattern with all inflammatory conditions. C4 was elevated, 58, CRPS are both elevated, ferritin just about, fibrinogen is elevated, as we expect with the high D-dimer. And there is a widespread chronic inflammatory picture. When you have 3 or 4 or more tests all showing inflammatory picture, you have to take it as inflammatory that is not cardiac or thrombotic. And we could save this lady a lot of unnecessary investigations or procedures. Anyway, so what is the D-dimer here? As you say, is the product of fibrinogen fibrinolysis. It can be high whenever fibrinogen is high, can be very high in serositis cases. Pericarditis, pleuritis, they have a lot of fibrinogen and D-dimer elevation with them, with no evidence of any clotting whatsoever. So you need to speak to all doctors to tell them this D-dimer is inflammatory, is not cardiac in any way. Adding to the picture, when you look at that, platelets elevated, which is a reactive to a chronic process, may well be inflammatory. Also, I did little audit about immature granulocyte. I submitted to the EULA about increased immature granulocytes again in inflammatory conditions. So I have 6 parameters showing there is inflammation. Why I need to go for cardiac investigation? And then, as we said, these serositis are quite associated with D-dimer. And in her condition, she's from Jordan, and her pericarditis-like picture is FMF pattern or IL-1-driven disease. And we treated with steroids and colchicine and no chest pain whatsoever since, and all parameters get better. And this is her D-dimer now 270 and fibrinogen down to normal. So we need to get lessons from serositis versus inflammatory investigation and how we assess these conditions. And the key message for me, that's not the final slide yet. We still have time for a bit more. But I utilize, when I deal with inflammatory condition, I utilize all the inflammatory tests available to me, try to assess this condition. First of all, to know this is inflammatory, not something else. Second, to know what type of inflammatory as well. Just like in pleuritis, if it is low C3-C4, it's going lupus way. If it is high C3-C4, it's going FMF way. That's one of, and that's how I put my condition in a table. One day I'll get enough patients to come up with something, but at least you see my patients, I've done ESR, CRP, fibrinogen, D-dimer, C3-C4, ferritin sometimes is not enough in this table, it was at the end, and so on. Platelets is part of it as well, which I mentioned in some graphs. So that's how you try to get the best opinion or the best picture rather than give half opinion. Well, I think it is this way, or I think it is that way. One of the problems here is in UAE, for some reason, it could be also in some Middle East countries, any pain in the foot is gout. And that is driving me mad sometimes. Yes, we know gout affects podagra, affecting skin, joint mainly. There is this entity of gout cellulitis possible, but it's very classical go into podagra. There are many people around with the element of enthesitis or tendinitis being classified as gout. And even if they have a little bit of CRP, oh, that's CRP of gout. And there are differences in ultrasound, as Professor Ahmed, he is expert in ultrasound, going to talk later. But you need to put these in context. Gout, IL-1-driven disease, comes in attack and going attack. CRP goes very high and then down to normal. While tendinitis is more taking chronic pattern and it's more CRP always moderately raised between 8 to 10 or something like that. So it's not the same pattern of the test. And this is when you talk about biomarkers, how to help you with differentiating condition. And let's go to the next slide. Yeah. So as I described the CRP, if it is elevated in enthesitis, fine, but you need to make sure there's no other comorbidity. But the important one, with enthesitis, I do these tests. One is fibrinogen. Fibrinogen, as I said, it gives me like a time factor. When it is high, I say this guy has 6 weeks of inflammation. That doesn't happen with gout. It is only a very high level of inflammation with gout, fibrinogen might go up, but usually not. Usually with the CRP 8 or 10 and fibrinogen high, this is enthesitis or tendinitis of spondyloarthritis pattern usually. Calprotectin, I do calprotectin more regularly. Calprotectin, if it is high, means the inflammatory process I am facing is more of intestinal origin because this represents an inflammatory biomarker in the stool. Mature granulocyte, it doesn't happen in every patient, but when it occurs, again, it helps me more to say this is more enthesitis rather than gout. And this is just one show of ultrasound there about tendinitis. But again, those people can have high fibrinogen. That's about one patient I presented earlier. And that would tell me or help me to say this is more chronic tendinitis rather than gout. There are a lot of people misdiagnosed that way, and we are coming to an end in terms of discussion, and I'm happy to discuss the matters. Some of you could be even more experienced than me. I'm happy to take any question. Thank you very much.
Thanks for your elegant talk, actually, and very impressive. And actually, most of the talks of the meeting were neglecting that such manifestation outside the joints. You know, they are very expert in the joints. Once you go outside, maybe you have some lost. Let me discuss first the questions that we have. First question coming from Professor Hajaz Al-Tamimi, asking, could serositis could be the presentation of rheumatoid arthritis?
Yes, I mean, I mentioned in the early rheumatoid arthritis, one of the features of serositis. But in my experience, it is very rare to be the presenting feature compared to lupus. Usually comes at the end. People have rather moderate to long-standing disease and not very well controlled, and they get serositis. That's how I see. I don't see many serositis of rheumatoid these days, but I remember my days in UK. We do see pericarditis, we do see pleuritis, and interstitial lung disease more often. I think with a good control of rheumatoid these days, a lot of these, what you call secondary features, are all coming down, from deformities to serositis to everything.
I think we really now we can then see Kaplan syndrome, rheumatoid nodules in the lung. It's very rare to see such cases now. Almost maybe 20 years back, we didn't see such cases.
Totally agree, yes.
So going for the next question from Dr. Navidi, asking which serositis, pleuritis, pericarditis, or ascites is the most common in SLE and why?
First of all, by the studies I show, pleuritis is the most common. I think the cases I see in Mediclinic, also pleuritis is the most recorded cases, I have to say. Is it by nature pleuritis is happening more, or is easier to be picked up? That is need to be answered in a good cohort of a study and academic unit, and we do scanning and echo and to everyone to try to compare. But is the first symptomatic. Plus, I don't know how many pericardial lupus are still with the cardiologist. They never refer to us. They just deal with them themselves. That's another problem. But pleuritis is the most common. I show in the what you call in the graph that around 50% is a pleura.
I think pleuritis is always commonly symptomatic. But effusion, pericardial, and ascites, we are seeing a lot. Could be always frequently asymptomatic.
True.
Okay. From Dr. Muhammad Hassani asking, is there a benefit from using conventional DMARDs or biological DMARDs in lupus-induced serositis?
Yes, I mean, the first lady I show, which she is stable now only on azathioprine. I could tell you if the patient is young and having these attacks as episodic, courses of steroids is enough. The patient running more like this lady, chronic phase with more repeated aspirations, I think that's when immunosuppression is needed. Since we put on azathioprine, she did not have any single aspirate. She is mainly symptomatically good. So I think that is the place. Some people classify pleuropericarditis as a particular subtype in lupus. They tend not to have other systemic features like nephritis with it or something like that. So it's a subset, and maybe one day perhaps will be called a particular syndrome or disease, I don't know, but till now it's part of the lupus. So when we have any lupus patient, you need to put them on hydroxychloroquine to minimize the long-term complication anyway. But as I said, it's patient to patient. Young patient, healthier, more clear-cut attacks, courses of a steroid will be enough.
Okay. I will discuss with you also about the FMF. FMF is always tricky. It is very difficult
Indeed.
to figure out most of the cases, unless to have most of patients coming with a big file with a lot of consultations, and
Yes.
finally you found FMF. I remember I saw last week one patient with almost the same file, a big file of many consultations and make reports, but he has a typical onset of arthritis. Looks like serositis with recurrent attacks and abdominal pain of MF. But actually, according to his file, he passed through all medication. He get colchicine for a long time, even Ilaris for some time, and Humira, but still have the recurrent attacks. The only remission he's going with is steroid. So if you're going to...
Well, that's against the book, which means most people, they don't respond to steroid and they respond to these. Is the diagnosis of FMF is the correct one? I don't know, but you see a couple of patients, why I mentioned inflammatory bowel disease. The inflammatory bowel disease can give you a non-specific high inflammatory picture without GI symptoms, or maybe just the abdominal pains. And that's why in this guy, the steroids help. Ilaris didn't help, as you say. Humira, I don't know why it didn't help. But in any situation, as Professor Basil said, if you think someone not respond to anti-TNF pericarditis, think of revising the diagnosis. I would probably try to sit and revise the diagnosis on this one.
They not respond to colchicine and Ilaris, so and
Humira. I mean that will make it strange. Ilaris is very potent.
Yes. Okay, coming back to the questions, we have a question from Anita Simone. I think this is could be a consultation. I have she passed through appendectomy 2 years back, and she has back pain after diagnosis of osteoarthritis due to back pain, and you have pain also in the knees, feet. Is this because of the appendix, or it was related to her? She has diabetes also and hypothyroidism. You have advice?
Well, appendix, I mentioned it in the context of wrong diagnosis of FMF. Appendix would not trigger anything. Appendix is just misdiagnosis at that time. But in your case, I don't think there is any clear link of appendix to any of the type of arthritis, maybe only a type of reactive arthritis. You had some sort of some mesenteric infection of some sort, and wrongly called appendix, and then you have reactive arthritis to some of it. So your arthritis need to be defined first. Is it osteoarthritis or reactive arthritis or whatever it is? And it has to be whoever expert next to you is to define that picture. Do you have reactive arthritis or not?
Okay, thank you, Rasir. Another question about a 13 years old girl presented with chest pain. She is
3 years.
Yes, 10 years old. Girl present persistent chest pain. She is known case of SLE with optic neuritis, diagnosed 5 years back. Her present chest pain revealed a very small area of inferior cardiac ischemia.
Yeah.
She 5 doses of steroid as well as first dose of Mapsera, and planned for first dose of cytoxan endoxan.
Yeah. This is a vasculitis-like picture with perhaps myopathy. I don't know if you mentioned pericarditis there, but this sounds more it's very premature type of vasculitis in lupus, and quite highly is inflammatory, not atherosclerotic, obviously. And yes, she is indeed needing the high aggressive treatment of a steroid and rituximab, maybe cyclophosphamide for this age. I don't know. Yeah, she's in young. I mean, for all this tough medicine. But yeah, but this is you will look at the pericardium. If you find little effusion, is it secondary to this vasculitic or is it primary of pericarditis of lupus? Nobody can tell you this in very accurate way. But if she's going to have a steroid, The serositis should get better anyway, but the vasculitis is the one needs to get better. That's the main thing.
Okay. Which DMARD you from Dr. Ruwaida? She's asking about DMARDs preferred for steroid sparing in SLE serositis.
For SLE serositis, and that lady, azathioprine, and azathioprine still perhaps reported a lot in the literature, is just good enough. The disease, the steroid sparing in serositis, you don't need to be very aggressive. I think it could settle in something moderate. Azathioprine should be fine. All the rest, if azathioprine fail, like methotrexate, mycophenolate, I could potentially use, but I don't have serositis with mycophenolate. Methotrexate, yes, more are azathioprine. You can talk about cyclosporine, for example, but for her age 73 and blood pressure, maybe this is not the one I fancy. Azathioprine sounds just settling her. Most cases will settle with that.
Okay, one more question from Dr. Nouri Osri asking for female, 39 years old, with elevated D-dimer, with chest heaviness, shortness of breath, recurrent attacks of inflammatory markers, ESR and CRB, not elevated, normalized, cardiac and chest are free, pulmonary CT angiography free, ANA, DNA negative, only ANCA positive. No other rheumatological symptoms. Pulmonologists consider pulmonary embolism secondary to autoimmune disease. She's asking if it is correct or not.
Right, okay. So you have two findings with this high inflammatory picture. You have ANCA positive, you have someone treat her as PE. First of all, how high is the ANCA, number one? Is it significantly high or just borderline high? Second, repeat, is it still positive or not? Three, does the case fit in a vasculitic description or not? I think still we should be following the principles of diagnosis. Is you go by the clinical picture, which direction it should take you. If this lady with a high inflammatory picture, a sign of pleuritis, whatever it is, and there is no lung lesion to suggest vasculitis, there is no hematuria to suggest vasculitis, and this inflammatory picture up and down, that takes you towards an episodic or recurrent pattern of inflammation, which is not the pattern of vasculitis. You might ignore ANCA here as you might have ignored, in that case, the tumor marker C125, because these are not specific and not diagnostic as such, only on a probability basis, all right? Second, if the other guy say treat as PE because of D-dimer, this is a common mistake, occur everywhere. And I keep telling my cardiologists, they are now aware, they discussed with me earlier now. At the beginning, I say, look, we have this patient. But in the past, they used to treat whatever they treat. And D-dimer, the clue here, when you get D-dimer on treatment of, we have this case with one of the lady. D-dimer should resolve within a week or two after treatment with the Clexane or whatever it is. If it doesn't settle down, means it's inflammatory, it's not a thrombotic. And that's another clue for you. You go there, see D-dimer after treatment. Is it coming down or not? It's not coming down, that's inflammatory. Treat the inflammation and tell the guy, okay, started anticoagulation on safety basis, but to make it short course, 3 months just to make sure, you know, see a safe side rather than you treat her for life or whatever. So that is, PE is not, D-dimer again is a test of a probability. PE, you need to see it either by scan or by clear Doppler ultrasound of the leg or by like intervention through venography and they get the thrombus out from the vein. That's when the pathological confirmation of PE. While D-dimer is a probability, most people, they don't understand the inflammatory component, so they take it as a clotting component all the time. And that's when you need to educate them, tell them, get some literature from Google, show it to them. And that's what I did. I struggled for a year or two before now they believe at anything. If it doesn't make sense, they come to me. And then I check that patient for them.
Okay, Dr. Asir, Dr. Higazi asking about hydroxychloroquine is useful for serositis? Or is it not enough?
Yeah, it's, I don't see much benefit. First of all, azathioprine, we use it as steroid sparing. Hydroxychloroquine is not for that purpose. Hydroxychloroquine doesn't help directly serositis. If you have a case, it helps serositis, that's very good. Let me know about it. However, hydroxychloroquine given under the lupus definition, because all experts, Michel Petri, Eisenberg, everyone, all lupus patients, they put them on hydroxychloroquine. It's not to treat serositis, but people on long-term hydroxychloroquine have less complication compared to people not on hydroxychloroquine. Perhaps on that basis, I started hydroxychloroquine for that lady, but she couldn't tolerate it. That's why we stopped at the end.
Okay, Dr. Mashaban asking about C3 and D4 elevation. What is the significance of that? I think
Yeah.
for information.
Why I regularly do C3, C4, were to differentiate these conditions. C3 and C4 get elevated because what they are complement consumed by the inflammatory process that with apoptosis occur in lupus. But on the contrary, they're produced as part of the anti-inflammatory reaction. So they go up with a systemic inflammatory picture, not with apoptosis of lupus. So they could go up in Still's disease, inflammatory bowel disease, and even just rheumatoid. They could occur, but usually in the severe level or intense inflammation. So when I worry about, let me say, pericarditis came to me, is that lupus or FMF? If I do C3, C4, as what I show you on the table, if they are going on the lower side, I go lupus way. If they are going on the higher side, I go FMF or other inflammatory diagnosis way, like Still's disease, for example. So that's how it helps me to decide which is which.
Okay, that's great. That's great. Dr. Asir, are you following a special protocol for colchicine FMF?
Colchicine protocol.
Yes.
I mean, most people, I don't know what is the protocol says because I just do my own things on day basis. I mean, most people, I give them like on average 1 gram daily for maintenance and up to 2 grams, 1.5, 2 grams on acute attack. But I try to tell them not to stop colchicine. Colchicine is the most effective therapy to prevent amyloidosis. When I treat the patient, I treat the patient not to have or develop amyloidosis. Well, the patients usually, they want only symptomatic treatment kind of thing, plus maintenance therapy preventing attacks anyway. So for educated people, they accept to stay on it long term as education, as preventing attacks. But there are many people who just, never get better, throw the tablets away. Those are sad people. I mean, I keep talking to them again and again, but we have the same scenarios repeatedly.
Okay. Maha is referring again for the COVID-19 and the colchicine.
Yeah, colchicine, the COVID-19 is very complex picture. There are many pathophysiological descriptions and many therapeutic approaches. Some of them failed. Colchicine has been mentioned as there is an IL-1 activity in COVID, and it's mentioned it might help. And I'm not sure if it's going to help or not. But the other thing is there could be, despite there is long infiltrate, with the very high fibrinogen and D-dimer, there is also serositis-like inflammation. So on that basis, and it's usually harmless, on that basis, I'm happy anyone would give colchicine for COVID. But how much effective you need a double-blind randomized study or any other observational study of large content to show the benefit or not? I think Professor Abu Jamal would know very well. I have a view on COVID-19. Up to the viral phase, I doubt anything going to help. But when there is the immune-mediated alveolitis as a reaction, you could potentially have IL-6 inhibition like tocilizumab or steroid perhaps would help. Does colchicine help on this phase? I don't know. I did not dig enough to give you experience or any information on this.
There also, I can add also, there is one paper published from Italy, I think from Milan, which is involving some patients with COVID, showing a good response to colchicine, but most of them was in early cases. So actually, according to our experience, we're saying a lot of medication showing some efficacy reported
Yeah.
and
Yeah.
cases which you can rely on actually if it's working or not.
Yeah. Well, the same story with hydroxychloroquine and then being taken off of the FDA against revoked it. Yeah, well, we don't know.
Okay, we have last question from Yasser. I think he's referring also for the patient 13 years old with SLE and vasculitis, acute heart attack, showing also an increased D-dimer. In this case, it is feasible to start heparinization or Clexane for this patient, or for how long? And I think also we should go for CT angio for vessels.
Well, perhaps I need to know more details on this case. What do you mean by myocardial injury or vasculitis injury, and which context? And the D-dimer, is it a true reflection of the ischemic thrombotic event, or is it
or just related to the vascular event?
Yeah. So perhaps that cannot be addressed as 1 minute on this lecture. Perhaps the whole case need to be studied carefully.
Okay, by these questions, I think we could close.
Yeah, I hope most audience find at least 1 or 2 points new to them they can benefit from it. And thank you very much, Professor Ahmed, for the invitation.
Always happy to have you with us, actually. Thank you, Dr. Asir. You can stop
Shall
sharing.
I stop sharing now?
Yes, please.
Yeah, okay.
So now I think